Access to Medicines platform is a non-profit organization which works with partners and multi-stakeholders in contribution to achieving sexual and reproductive health and rights. We do this by creating a strong civil society that engages effectively with the government, the private sector, and other stakeholders accountable for health systems with an aim to deliver equitable, accessible, and highly quality sexual and reproductive health rights and services.
Access to Medicines platform came out of a desire for us to find a way in which we can engage communities in the work that we do. And primarily our work is focused on sexual and reproductive health and rights, using evidence, getting the voices of communities in the implementation of the work that we do, and making sure that the voices of community-based organizations are represented in the policy interventions, in the discussions, and in the discourse that goes around at higher levels in terms of ensuring that there is sufficient budget allocation and people have access to life-saving commodities, particularly for reproductive, maternal, and child health.
Access to Medicines platform was established in October 2016 and formally registered in Kenya in January 2018. Since then, we have been working with our partners to realize our vision of a country where everyone enjoys optimum health and rights, particularly sexual reproductive health and rights. Our main interventions include evidence-based policy and budget advocacy, multi-stakeholder engagements, media engagement, research/evidence generation, capacity strengthening of grassroots civil society organizations, as well as community engagement. In advocacy, Access to Medicines platform recognizes the need to prioritize sexual and reproductive health and rights at all levels of policy formulation, implementation, planning, and budgeting. This is likely to increase access to relevant and up-to-date sexual and reproductive health services, information, and commodities even to the most vulnerable and marginalized communities. We have implemented our advocacy interventions in collaboration with local community-based organizations, also known as CBOs, in various counties across Kenya. For the last 3 years, we have trained a total of 45 CBOs from 12 counties in Kenya. Our multi-stakeholder approach is different as we go beyond just talking about issues. We facilitate roundtable discussions between multi-stakeholders from private, public, mission sector, academia, and CSOs network to generate innovative solutions to the tough problems of supplying the right services and medicines in hard-to-reach areas and marginalized groups at the right prices for the right quality and in a timely and accessible manner. We support national and county-level multi-stakeholder dialogue space which strengthens governance and promotes a rights-based approach. We also provide high-level strategic multi-stakeholder partnerships to lobby and advocate for strengthening policies and processes that support reproductive, maternal, newborn, child and adolescent health. Over the years, we have had several multi-stakeholder engagements that have yielded great outcomes. In partnership with our national CSOs partner, the Health Rights Advocacy Forum, HERAF, we held a feedback forum in Isiolo County that created a platform for the discussion between the county health management team and CSOs on the status of the Universal Healthcare Program implementation in the county. We have also conducted other multi-stakeholder engagements in Narok, Kisumu, and Kakamega counties. The main objective of these forums were to share our findings of the study on availability and affordability of SRH commodities and review the recommendations, and also develop a joint action plan to improve access to these commodities and reduce incidences of teenage pregnancies, maternal deaths, and STI infections. In the Kisumu Dissemination Forum, various leaders of the county committees were also present and expressed their gratitudes to Meta Kenya for conducting the research and doing the dissemination.
Well, the study on SRH commodities availability, we welcome it, and it's quite informative because it actually shows us which areas that we are weak on and we need to work on, like when we talk about SRH commodities stockouts, availability, and this means we have to plan and budget for certain commodities, and basically it only shows us which areas that we really need to exploit, where we do well and where we're not doing well, so we need to improve on areas that we are not doing well.
The importance of reproductive health means a lot to the development of the county itself, and to me this meant a lot. Learned a lot, But I think we just need to put strategies for promoting the reproductive health, particularly not just on the three groups, but in the general population.
And you talked about sensitization of people on matters of SRH commodities. And we are thinking as an assembly right now, and it's going to happen very soon, we're going to have what we call Kisumu County Community Health Volunteers Bill. This is what will help us address the issues of CHVs, who will help us in sensitization of communities on matters of SRH. I know we cannot take our director to go to SEM to do sensitization, but if we have a bill on how we engage the CHVs, then on issues of sensitization, and if we work close with other partners, then we shall address the issue of sensitization.
Our biggest consumer is the health sector, but it's not enough because our local revenues, we are budgeting at 1.5 billion, which in essence we need to think of how to raise 5 billion. So some of the shortcomings that we have is because of our local revenues. We are not able to collect enough locally. And for that matter, as we speak now, there is what we call the rates, the evaluation roll, which is in process, and very soon want to believe it will be approved by the Assembly. Anytime from now, once we get money and pay those who are handling the evaluation roll, then that automatically will change our local revenues. And once we get more local revenues, I also believe we shall be able to address some of the challenges that we are having.
The work of advancing and strengthening health systems has not been possible without the support of the media.
For us at Meta Kenya, we've been very privileged because we have had the opportunity to engage and to work with media across the divide. The partnership that we worked with, that is the Health Systems Advocacy Partnership, one of the key activities they did is to formulate the Africa Media Network on Health. And as Access to Medicines platform, we actually spearheaded the formation of the Lower Eastern chapter of this media network in health. And this means that because of this, we have been able to have access to this media, to share with them the work that we do, to highlight important stories, important gaps in the health sector, to highlight issues within the study that we do on availability, affordability of SRH commodities for maternal, child and newborn health. And the media have been key allies and partners in making sure that this messaging is actually reaching far and wide, and specifically the people that are able to make decisions around this.
The media plays a key role in disseminating information, educating the masses, and health reporting on emerging issues of human interest. Access to Medicine's platform has increased its media engagement so as to create more awareness and visibility of a range of health topics including maternal, child and adolescent health, snakebite incidences, as well as mental health policy, care and treatment.
For children like calcium gluconate, the ORS co-pack, which is necessary for diarrheal diseases, availability is below 30%. And we are wondering, why is it the case? Is it because these children cannot speak for themselves? We probably need to scale up advocacy for newborn and child commodities.
In 2019, we hosted media and multi-stakeholder engagement forums in Kakamega and Kisumu counties, where the media covered stories on our research interventions.
We are in Kakamega County today to support a multi-stakeholder engagement that has brought together policymakers from the County Health Department, from the County Assembly Health Committee, and civil society organizations working in all the sub-counties in Kakamega County. The main aim was to share with them findings of a study that we did on the availability, affordability and stock out of reproductive health commodities for maternal health, child health, newborn health, treatment of sexually transmitted infections and contraceptives. And so we needed to get the input from the county and to chart a way forward on how we can improve the maternal indicators and the neonatal child indicators.
Our executive officer was also highlighted in the media sharing of the 2018 study findings on availability, affordability and stockouts of SRH commodities. From the same engagement, our executive officer was invited to a TV interview on maternal health status in Kenya and was able to share some of the key findings related to the availability and affordability of maternal health commodities and shared her evidence-based perspective on the topic.
Over the last 4 years, we did a study to look at availability, affordability of sexual and reproductive health commodities for maternal, newborn and child, and STI infection. And of course, the findings that we discovered were actually really matching towards the Ministry of Health itself found out. That number one, these commodities are not available. And you can imagine magnesium sulfate, which is used for treating postpartum hemorrhage, costs about 7 to 12 days of wages. So you can imagine a government worker who is on minimum wage. They will need to work for 12 full days for their wife to be able to get treatment for postpartum hemorrhage.
What informs this shortage, knowing very well that we've equally seen lots of donors coming on board towards, donating these commodities so at least they can be shared far and wide?
Yes. In fact, we have interrogated the results and engaged with the counties where we've conducted this study. And most of them actually attribute one of the biggest problems to issues of the supply chain. Of course, supply chain really is directly talking about cancer.
There was also news coverage of both our Kisumu and Kakamega dissemination forums where our executive officer spoke about the low availability of newborn and child health commodities in Kisumu County.
Our further request is that if you can find it in your own budgets, also to help us in equipping some of these facilities. Because they're open, maybe we lack furniture, and also we also have some medical equipment that we are supposed to put here, and probably we are not comfortably able to facilitate purchase of these equipment.
In Kakamega County, the Sexual and Reproductive Health Coordinator spoke about postpartum hemorrhage being one of the leading causes of maternal deaths and how COVID-19 had affected blood supply that they previously got from universities to aid mothers who bled heavily during birth. We have also been able to commission 2 documentaries, one on SRH commodities with a focus on Kakamega and Vihiga counties. This documentary is aimed at getting first-hand perspective from communities, service providers and policymakers on the challenges they face in accessing SRH services and commodities. The second one was in Narok County, whose focus was documenting success stories of the work we have done in the county and the challenges faced by communities in accessing SRH commodities, services and information. In our work of conducting evidence-based advocacy interventions, research is one of our key technical strategies. To this end, we have conducted a series of 3 surveys on availability, affordability and stockouts of sexual and reproductive health commodities in 10 counties across public, private and mission facilities in Kakamega, Kisumu, Narok, Nakuru, Makueni, Mombasa, Kwale, Nairobi, Meru and Isiolo counties. The findings and recommendations from these studies conducted between 2017 and 2019 have been analyzed and packaged into various knowledge products including the full reports, infographics, policy briefs, press releases and presentations. Access to Medicine's platform is a hub for timely, actionable and reliable data as evidenced by actions taken by counties in considering and requesting for county-specific data to enable them to interrogate and implement recommendations.
Most important components of advocacy is data, and so not only did Meta Kenya support us with the advocacy training skills, but they also supported us by giving us the data, by conducting the researches in Kisumu County, so that we can be able to work with the data they have to push our advocacy efforts forward. So the relevance of that training was so much because the data they also supported us with on top of the advocacy training, that made the whole difference, and it is what has made us get the gains that we are seeing as Kisumu County Meta Kenya CSOs Alliance.
From our research activities, a member of the Isiolo County Assembly sponsored a motion to set aside funds to establish 2 youth-friendly centers and therefore improve access to SRH services, commodities and information for the youth. Our CSO partner in Kisumu County used the 2018 report to develop a concept on advocacy for increased budget allocation for SRH commodities in Kisumu County.
As an institution, we sat down, looked at the recommendation that were calling upon more finances to avail more affordable SRH commodities, and it was talking about the availability, looking at the availability and the access. So as an organization, we were looking at how this is a matter of budget advocacy issue. And we sat down, tried to look at the recommendation, tried to look at the gaps in Kisumu County, and brought on board other partners who help us to come up with a concept which we later shared with our key partner, that is Women Deliver, and under their Young Leaders program, they managed to fund the idea.
This concept was funded by Women Deliver organization, and its activities are ongoing. The Kakamega County Health Management Team used the recommendations in our 2018 report to make a case for the increase of funds within the county health budget. Our research report has attracted interest from the Kwale County after the governor asked the 2019 report to be presented to the cabinet for implementation of its recommendations. Through the Health System Advocacy Partnership, we conduct annual capacity strengthening workshops targeting community-based civil society organizations operating within the counties with knowledge and skills to conduct evidence-based lobby and advocacy.
There before, we didn't have a better way of approaching the challenges that we have in Kisumu County, challenges that we have in running our programs in Kisumu County. But after the training, we came to realize that majorly our programs are, coordinate with the county government, that is the executive and the county assembly. And majorly there before, it was more of antagonism or a war. But after the training, we realized that we can do these things in a friendly manner.
We've worked with Meta Kenya. This, I think, they are our third year, and I can attest that out of the research they are doing on sexual reproductive health commodities, as an individual organization, we've managed to go through the research. Actually, we got this through their dissemination activity when they were sharing with us the outcome, and also we participated in the entire process, including the validation.
In 2018, we strengthened the capacity of 24 CSOs in policy advocacy, evidence-based advocacy in a forum that brought together a total of 25 local civil society organizations working in 11 counties in Kenya.
I want to attest we have seen a lot of changes as an institution. It built our financial base. And the second thing, it enables us to engage the county government. They bought the idea. I can recall last year when we were talking about increment in the docket of SRH.
In 2019, we strengthened the capacity of 24 CSOs in budget advocacy, budget cycle tracking, as well as social accountability in training forum that brought together a total of 28 local civil society organizations working in 12 counties in Kenya.
The Meta Kenya CSOs Alliance was established in 2018, and this was after the training that was convened by Meta Kenya in Nairobi, and we were trained on the use of evidence, policy advocacy, and effective communication in advocating for sexual and reproductive health and rights, as well as commodities. And after that, we asked ourselves, wow, now after acquiring all this knowledge, we can't just let it rest somewhere. So we decided to come together as a network of grassroots organizations to leverage on our strengths and weaknesses, and that's how we came up with this alliance, just to put into practice whatever we had learned from the training, and then also just to carry on with the advocacy at the grassroots level. I remember when I joined the alliance, it was just an idea that I had, but then through that I was able to get a support system that catalyzed the process of registering an organization, and in that I've been able to acquire a lot of leadership skills.
In 2020, we strengthened the capacity of 20 CSOs in proposal writing, resource mobilization, budget advocacy and tracking, and gender-responsive budgeting.
We have a very close partnership with Meta Kenya, which has actually built our capacity in terms of advocacy skills, as well as the ability to track the budget cycle, the ability to enable us to participate and influence budgeting towards health issues. So we as a network have impacted so much on health matters in Kisumu County. Previously, there have been networks, but there's never been a network on health matters. So this has been a very unique network that is looking at health and justice. Now, our focus on sexual and reproductive health and rights has been the main idea here, where we have been engaging the county government of Kisumu to come clear and to respond to issues of sexual and reproductive health of girls and young women.
All these CSOs represent our network of local organizations from 20 counties, namely Nairobi, Meru, Homa Bay, Siaya, Busia, Bungoma, Kakamega, Narok, Elgeyo Marakwet, Nandi, Nakuru, Kisumu, Vihiga, Bomet, Kwale, Mombasa, Kajiado, and Isiolo counties that work closely with us as our implementing partners on sexual and reproductive health, gender-based violence, women empowerment programs, youth and adolescent networks. The outcomes of our capacity strengthening interventions include formation of a vibrant youth-led CSOs network in the Lake Basin region that after 3 years is now engaged at the highest level, both at the County Ministry of Health and County Assembly. Our trained CSOs in Kisumu, Kakamega, Kwale, Narok, Kajiado and Kiambu counties have advocated for the development and enactment on key policies for sexual and reproductive health and rights, including health bills as well as adolescent sexual and reproductive health policies. We have also trained CSOs in Kajiado and Busia counties, and through their advocacy efforts influenced the establishment of youth-friendly centers. Through our trained CSO partner, Youth Alive Kenya, more than 50 youths in Kiambu County were trained on budget advocacy and social accountability. As a result, social accountability forums are formed and community scorecards administered in 6 sub-counties. Trained CSO partner Afya Africa advocated for the implementation of the Return to School policy and ASRH policy in Narok County. Under community engagement, Access to Medicine's platform seeks to ensure that community voices are represented in policy formulation and at the decision-making levels. For communities to hold duty bearers accountable, they need to be aware of their sexual and reproductive health and rights. Through our CSO partners, we held community engagement sessions at the lowest level. We have supported community dialogues, youth empowerment and educational forums and sensitization on sexual reproductive health right matters, social accountability and public participation. We have also effectively organized County World Health Days, including World Contraceptive Day, Day of the Girl Child, Day of the Youth and World Mental Health Days. In addition to that, we have also supported our community-based members to participate in radio talk shows in the local dialect so as to reach out to even the most marginalized with information on reproductive, maternal, child and adolescent health, as well as the Ministry of Health messaging around COVID-19 preventive measures. Access to Medicine's platform was invited by the Division of Reproductive and Maternal Health Unit of the Ministry of Health to support the process of reviewing and finalizing standardized National Reproductive Health IEC materials. We also supported the final review of the Family Planning Training Manual, which should be used to train healthcare professionals on the long-acting contraceptive method, hence reducing the fertility rate and increase the contraceptive prevalence rate among women of reproductive age in Kenya. We have also been involved in the building of structured and functional engagement platforms among policy and decision makers and CSO networks in Kisumu, Kakamega, Kwale, Narok, Kajiado and Kiambu counties that have resulted in the development and enactment of key policies for sexual and reproductive health and rights, including family planning costed plans, health bills and ASRH policies. Our research and evidence generation activities have been adopted and supported evidence-based policy and budget making in Kisumu, Kakamega, Narok, Kwale, Kisumu and Isiolo counties. So far, we have an empowered network of over 40 local civil society organizations from 10 counties that are able to effectively hold policymakers accountable for implementation of SRH policies, leading to refurbishment or integration of over 200 more youth-friendly centers and corners. Meta Kenya is recognized by key stakeholders in both the national and county level in Kenya as an accountable policy influencer in the SRH domain. We have participated in identification, training and engagement of male champions for maternal and reproductive health, particularly in Narok, Kwale and Kakamega counties.
One of the things is our women here, they work a lot. They go fetch firewood and water. So the first trimester of 3 months of pregnancy, some miscarriage. And then the last 3 months, they also do a lot of work and some miscarriage. But the worst of the worst is getting that phone call in 2 a.m. and then the roads are impassable, so you can't help anyone.
We have been at the forefront in the advocacy for health system strengthening that has seen an improvement and increased budgeting for health infrastructure in Kisumu and Kwale counties.
The one thing that we've done as a network is that we've contributed a lot ensuring that there's more resource allocation. For example, this year we are having over 60 million for SRHR, but last year it was 47 million. There's an increase, but that has happened because we were targeting a specific decision maker, which is chief officer within the county.
Health Action International, which is based in Amsterdam, has been very instrumental in terms of giving us technical and financial support to be able to start up and to do the work that we do. We have worked very closely with HI as part of the Health Systems Advocacy Partnership, which is a program that was funded by the Ministry of Foreign Affairs of the Kingdom of Netherlands and was really looking at health system strengthening around sexual and reproductive health and rights. And it is a project that was implemented in 5 countries, including Kenya, Uganda, Zambia, Tanzania, and Malawi. Access to Medicines platform was the point organization for HI here in Kenya.
In 2019, we implemented 4 main programs, namely the Health System Advocacy Partnership, the Mental Health Project, the Snakebite and Venoming, and the Learning and Linking Project. Over the last 4 years, Access to Medicines platform has been the implementing partner of Health Action International as part of the Health System Advocacy Partnership. The partnership is implemented at global, regional and country levels in Kenya, Uganda, Zambia, Tanzania and Malawi. This strategic partnership involves AMREF Health Africa, the Africa Center for Global Health and Social Transformation (ACHEST), Health Action International, implemented the country by Meta, and WIMA's Foundation, and is funded by the Dutch Ministry for Foreign Trade and Development. This partnership has strengthened civil society organizations and other multi-stakeholders initiatives in Kenya, Uganda, Tanzania, Malawi and Zambia, and also contributed to health system strengthening, particularly sexual and reproductive health and rights. Through the Health Systems Advocacy Partnership, many outcomes have been improved, including access to sexual and reproductive health services, information and commodities have been realized.
Access to Medicines platform came out of a desire for us to find a way in which we can engage communities in the work that we do. And primarily our work is focused on sexual and reproductive health and rights, using evidence, getting the voices of communities in the implementation of the work that we do, and making sure that the voices of community-based organizations are represented in the policy interventions, in the discussions, and in the discourse that goes around at higher levels in terms of ensuring that there is sufficient budget allocation and people have access to life-saving commodities, particularly for reproductive, maternal and child health.
In 2019, we conducted the Mental Health Project in partnership with Tinada Youth Organization in the implementation of Mental Health Integrated Program within Western Kenya in partnership with Open Society Institute for Eastern Africa. The focus counties surveyed were Vihiga, Kakamega, Bungoma, and Kisumu counties. Through our support, Tinada was able to undertake evidence-based advocacy to improve mental health policy formulation and implementation in the region. We supported development of research tools, training of research assistants, data collection and analysis, as well as report writing. The research sought to expose a myriad of challenges in care, treatment, perception, and hardships faced by persons with mental health and their caregivers. We seek to implement the following recommendations from the research: enhancing referral systems between county-level facilities and level 4 and 5 facilities, and improving lower-level facilities by increasing drug supplies and professional staffing. Fast-tracking the enactment of the Mental Health Bill 2016 and incorporation of comments from multi-stakeholder dialogues on the Kenyan Mental Health Amendment Bill 2018 initiated by Senate. Inclusion of distinct mental health reporting indicators in the current reporting tool and in the DHIS2 portal. Support trainings of CHEWs and CHVs in the utilization and administration of the tools adopted. Improve mental health infrastructure at the county, sub-county, and community levels by constructing government-owned mental health rehabilitation centers in the target counties. Strengthen mental health budget advocacy at national and county level in order to increase mental health budget investments in order to improve community-based mental health programs that promote the rights, dignity, and social inclusion of persons with mental health conditions and psychosocial disabilities. Establish and strengthen county mental health secretariat committee and technical working groups at both sub-county and ward levels. In 2017, the World Health Organization declared snakebites as a neglected tropical disease.
My name is Dorothy Okemo. I lead the work on snakebites here in Kenya on behalf of Health Action International, where we have focused our efforts in 4 main counties with the highest incidences of snakebites, that is Kwale, Kilifi, Taita Taveta, and Kajiado counties. Some of the work we do is around research and collection of data on the cases of snake bites, sensitization of communities, and engaging with the counties to make sure that they are able to develop robust policy framework for the care and management of snake bites in the individual counties.
In partnership with Health Action International, we supported research and evidence generation at both facility and community level on treatment, care, access to commodities and knowledge levels, including support some CHMT meetings where the findings of our research will also be shared to scale up advocacy. We also advocate for provision of care and treatment of snake bites in the lower level facilities where most bites occur. We also conduct joint community sensitization programs on snakebite prevention measures, first aid information, and access to treatment at health facilities. We also facilitate workshops and capacity strengthening of health workers and support in our county discussions around prioritization of treatment of snake bites. We have taken part in the dissemination of the Ministry of Health clinical guidelines, which provides healthcare workers, community members, and civil society with our practical tools for awareness raising, prevention, treatment, and management in our focus counties. In advancing the implementation and achievement of long-term outcomes for the Health System Advocacy Partnership, Access to Medicines platform led the Learning and Linking project and worked hand-in-hand with all the health system advocacy partners in Kenya with a view of ensuring that all the sexual and reproductive health components on commodities, human resources for health, governance, and finances were well covered. The concept was developed to help support efforts by context lead around the consolidating activities that contribute to better outcomes. Other key collaborators in this project included the Ministry of Health, the county government health officials, and local CSOs in the target counties. Some of the activities supported by this project and their outcomes include review of the 10-year Kajiado Health Bill, whose draft was endorsed by the civil society organizations and county health management team. Sensitization of health workers on dignity and ethics at Siaya County Referral Hospital. Kakamega County Integrated Commodities Security Technical Working Group. Kajiado County Inception Meeting with the County Executive Committee, Chief Officer and the County Director of Health to discuss joint engagements and collaborations, as well as brief the county executives on work done by the Health Systems Advocacy Partnership. We also participated in the World Contraceptive Day celebrations hosted by the County First Lady and County Health Management team in Nabaholo, Kakamega County. This provided a platform for demand creation and awareness on use of contraceptives to the residents of Nabaholo as per SRH Commodities study recommendations. Sensitization of Kajiado health workers on improving maternal and perinatal death surveillance and response as a way of reducing maternal mortalities and reporting of the same. From the forum in Kajiado County, a total of 20 participants from 3 sub-counties were sensitized on the MPDSR Guidelines 2016. The teams were taken through data tools and the importance of availability of the audit and notification forms at the facility level. This aimed at improving their understanding on essentials of quality data. We supported a 2-day comprehensive postnatal care and guideline sensitization in Kakamega for 27 members of the CHMT from all sub-counties. We supported Siaya County Multi-Stakeholder Forum organized by the Unguja Youth Parliament on leveraging SRH access for UHC impact in Siaya County. We supported KMPDU Dialogue Forum on sensitization of health workers in Siaya County on dignity and ethics for health workers, which was attended by 100 service providers. We supported a maternal perinatal death surveillance and response sensitization forum in partnership with the county government of Kajiado that brought together 20 CHMT, SCHMT and hospital superintendents from 30 sub-counties. In the year 2020, the COVID-19 pandemic hit the nation of Kenya, with the first case being reported in the month of March. For us, one of our main interventions mostly affected by COVID-19 pandemic is our annual SRH Commodities study. We were not able to conduct this year's survey because of the lockdown in Nairobi and other COVID-19 measures put in place.
Yes, COVID-19 really is a monster that nobody really expected to come this year. We all had so many plans of what we wanted to do on the ground, but because of the containment measures that were put in place, this meant that we had to really scale down on the community engagement programs that we had planned. So this has meant that we have had to transition our work to be mostly online, which has really disadvantaged the constituencies that we represent. Not many people in the rural areas are able to access smartphones or internet or Wi-Fi, such that even as we are able to engage at this level online, these marginalized communities continue to be disenfranchised because they cannot be part and parcel of the conversations that we have. We cannot reach them and access them so that we can then amplify their voices around the needs and the gaps that they have.
COVID-19 also affected the uptake of reproductive, maternal, newborn and child health and sexual and reproductive health services and commodities. This is evidenced by the indications that arose during our dissemination forums in Narok and Kisumu counties. For instance, in Narok County, there was a halt in provision of maternal and child health services at the county referral hospital during the initial stages of COVID-19 outbreak. Being an organization whose goal is to ensure everyone everywhere has access to affordable and effective sexual and reproductive health services, information and commodities, we undertook an initiative to conduct a mapping exercise in 5 sub-counties of Kakamega County and the uptake of reproductive health services RAMCA during COVID-19.
When you have a county that is very responsive to the needs of its citizens, as we know in Kakamega they have the Oparanya care that is really passionate about making sure that women go for the antenatal visits and children get immunized. Then they come up with strategies that can mitigate the effects of COVID. So in Kakamega, for example, I know what they did is to talk to the border people and give them passes that would allow them to transport pregnant women or women taking their children to the facility for immunization without being harassed. They also found a way of availing this permission slips at the lowest level facilities so women can access this, and this can be signed by the chief, and this really allowed the women to access services. So when you look at the mapping exercise that was done in that county, it is actually very surprising that during this time when the containment measures were in place, there was actually no effect or a positive effect in the number of women that were accessing health services, particularly antenatal care, postnatal care, and skilled delivery.
The reports submitted from these 3 sub-counties showed that COVID-19 not only posed a hindrance in the uptake of RAMCA services, but also in the delivery of services. In Malava sub-county, for instance, the CHVs feared visiting patients in the homes due to lack of sanitizers and protective gears like masks.
At first we had a hard time due to corona. The reason being we didn't have protective materials, but then we were given some masks and sanitizer. So we went to do the mapping and we found our mothers. Most of them had even not come for their ANC. So we asked them why. They said they fear hospital because of corona. But then we talked to them and they understood us and they continued coming to the facility for their ANCs.
Ikolomani sub-county reported poor hospital visitation by pregnant women and family planning clients for the fear of quarantine in case they tested positive for COVID-19 or being infected from the facilities.
Most of our mothers deliver at night and they were supposed to be ferried to the facility. So we realized after the uptake of those services in April, we realized we were not diving. In fact, even if we went to the facilities, clients were not there. Our maternities were almost empty. Our family planning entities were empty. They were vacant. Mothers were not there. So we did go back as a county on the drawing board. What is it that these mothers, what happened? Why did they stop coming in the facilities? So we find the issues of curfew were there. There were issues of the fear of unknown, which was they feared they might get corona infections in the facility.
All the sub-counties reported fear of clients getting infected by COVID-19 being one of the major hindrances to accessing RAMCA services.
Then all of a sudden, they see in MCH clinics, they are seeing nurses putting on masks. They are seeing everybody's in masks. These mothers, they ran away. They feared thinking that we will also get coronavirus. Even some of us who come from communities, when mothers were seeing us in the communities, wanasema huyu anatoka kwa hospitali yako na corona, they ran away from us.
We had to go back to the drawing board and reinvent ourselves and see what else we can do within the sphere of COVID-19. And so one of the things we did is to scale up advocacy with the CSOs and community-based organizations in the different counties to make sure that reproductive maternal health services continue to be provided in spite of the COVID measures that have been put in place. In Narok County, for example, in partnership with our CSO partners, we did a lot of lobbying and advocacy to make sure that the county referral hospital is actually opened up for mothers, women and children to access services when they need them, because this was one of the centers that had been identified as an isolation center. And this meant that many life-saving services were not going to be accessed by these women. When you look at Kakamega County, for example, we actually had to engage with the county and make sure that they come up with strategies that would allow pregnant women to be able to go to the facility without undue harassment and without the curfew timings affecting this. If this had not happened, we would have lost a lot of mothers because of the containment measures. We also supported a mapping exercise to look at the impact and the effect of COVID measures in all the sub-counties in Kakamega County, just to make sure that the reproductive, the maternal, the immunization, antenatal services are at par and are still provided to these women and these children who really need these services.
Our vision is to see a country where everyone enjoys optimum health and rights, particularly sexual reproductive health and rights.
We feel Access to Medicine's platform is really filling a gap that is real and that exists in our country today. We are providing that opportunity for the community voices at the lowest level in every corner of this county to be heard. We are really advocating for decisions to be made based on the needs in the community. We believe that one size does not fit all. And that is the reason why we prefer to work in the county and come up with strategies through our multi-stakeholder platforms that are not only listening to the voices of the communities, but are basing the policies, the discussions around evidence that has been collected that is very specific to these counties. So we really feel that we have a critical role to play in bringing the voices of the communities to the table and making the policy and decision makers responsive to these needs.
We would like to thank our partners who have worked together with us into seeing the impact that we have created in Kenya and beyond in championing for sexual reproductive health and rights. To partner with us, please reach us on info@atmplatformkenya.org or call us on 0712 270 458 or visit our website at www.atmplatformkenya.org.